Hi, my name is Casey Halpern, and I am Professor of Neurosurgery and Chief of Stereotactic and Functional Neurosurgery at the University of Pennsylvania. I also direct the Stereotactic and Functional Neurosurgery Fellowship Program, where fellows who are trained at residencies across this country come to seek further training in this incredible subdivision. Much of what we do as neurosurgeons in this unique specialty is deep brain stimulation surgery. This is the procedure that I focus on in my practice, using it for people with movement disorders, that is Parkinson's disease, essential tremor. We've made incredible innovations in the field of deep brain stimulation very recently that our patients are actively benefiting from. I'm excited to share these innovations with you. In addition to that, I'll share some perspectives as a neurosurgeon who has uniquely built a practice working very closely with the movement disorder experts here at Penn, but also working with neurologists both at Penn and in the community. We will give a general overview of deep brain stimulation, where we are, how it impacts patients. I'll share some evidence with you, share a little bit about patient satisfaction. There are different surgical targets that we use, and it's important to keep those in mind as you're programming the device and considering this therapy for your patients. There have been innumerable innovations in the field of deep brain stimulation. Very grateful to Boston Scientific for bringing us some of the latest and greatest of these innovations for our patients. And it really is allowing us to more efficiently take care of patients and really deliver the best possible outcome for their condition. So you can see here a schematic of the deep brain stimulation implant. I often refer to this as a pacemaker. In fact, some of the original deep brain stimulation devices were very much like pacemakers for their heart, but of course, instead of the wires being placed in the heart tissue, they're actually placed in the brain. Most surgeons, like myself, start in the brain carefully or stereotactically, meaning using image guidance, can deliver the electrode safely and precisely into certain parts of the brain, and those wires then get connected or locked in place at the skull. The area is then sealed, and then the wires are brought over to the side of the head, and then either at that time or at a later date connected to extension wires and tunneled under the skin down to the chest, and that's where the device is often placed. We've been doing this surgery for a long time for patients, and we've seen dramatic improvements in their quality of life. Thanks to some recent innovations by Boston Scientific, we're really able to actually deliver better care to these patients and get them better faster. One reason for that is that there's new electrodes that are available. These electrodes are extremely well made and rigorous. They are intended to be lifelong, and they also offer multiple areas along the tip of the wire that can deliver the therapy, meaning our patients and our programming neurologists have so many options to optimize the therapy. So here's some facts about deep brain stimulation you should know. This is FDA approved for patients with Parkinson's disease and essential tremor, reimbursed by Medicare and other insurance companies, private payers. Often there can be a deductible or a copay, but these are procedures that are standard of care for patients with Parkinson's and essential tremor. A huge advantage of deep brain stimulation is that it's non-destructive. This is not an ablative treatment that could be irreversible and lead to potential problems for patients. Rather, the stimulation can be delivered in a reversible and adaptable fashion. It's titrated to the patient's symptoms. I always tell patients who are often fearful of the idea that brain stimulation is getting delivered that if there is a problem, the device could be shut off. It's very rare for patients, obviously, to ask us to shut the device off. But certainly adjustments are necessary, especially because we expect these symptoms to worsen over time. And so the ability to adapt in time with the patient is really, really critical. These devices are conditionally approved for MRI, full body MRI. And so often patients with one of these conditions may need to get an MRI for an unrelated problem. You can see here, over 250,000 people have been implanted for deep brain stimulation therapy, largely for Parkinson's disease and essential tremor. The overwhelming majority would do it again and have had positive experiences. This is such an incredible piece of feedback. more than 98% of patients would say they would do deep brain stimulation again. I'm not aware of a treatment in clinical neurosciences, in neurosurgery, a procedure, of any kind that has that level of satisfaction. There's so many things that deep brain stimulation can do to help your patients. So let's start with Parkinson's disease. The first thing that's obvious is that it can reduce their motor symptoms. The three cardinal features of Parkinson's disease: tremor, bradykinesia, and rigidity. Patients can generally get tremendous benefit in these symptoms, and I would say we generally expect 80% reduction in tremor, 60-70% reduction in these other symptoms. Often patients really want to understand ahead of time what can they expect themselves. And so I actually offer doing on-off testing to patients in our clinic. Medications for Parkinson's are extremely helpful in general, but at higher doses and in some patients who are particularly sensitive to the medication, there can be side effects. The most common side effect is dyskinesia, which is actually a hyperkinetic additional movement disorder that's not generally part of Parkinson's without the medication. This can actually get better because deep brain stimulation can allow patients to lower their medication, so it's actually an alternative to medication. But it can also get better because some forms of deep brain stimulation therapy, specifically targeting the palatal part of the brain, can actually treat the dyskinesia and even allow patients in some circumstances to stay on their medication and tolerate it better. Patients with essential tremor, obviously a different diagnosis, more specific to action tremor, where they have really poor coordination of their hands. Deep brain stimulation has been long demonstrated to be helpful in reducing tremor. Anywhere between 60 to 90% reduction in tremor has been reported, and that's common in my practice as well. And that can be particularly helpful for patients that are experiencing side effects of medications that are prescribed for essential tremor. If we offer something like deep brain stimulation, one of the goals is usually to replace the medication with the therapy as well. So across these two diagnoses, these are potentially life-changing effects. Deep brain stimulation is an incredible therapy that we have to implant into the brain and the chest. The wires that are implanted in the brain, they target regions of the basal ganglia and or the thalamus that can be really helpful for people with movement disorders. And so starting with Parkinson's disease. In general, there are two parts of the brain that we use most commonly. One is the subthalamic nucleus, also known as the STN, and the globus pallidus interna, that's the GPI. Let's do one at a time. So the STN, the subthalamic area, this is a tiny structure about the size of an almond or smaller that sits under the thalamus and has been found to be heavily involved in tremor. So if we have patients, especially tremor-predominant Parkinson's patients who really can't get medication to control the tremor, this is really the best target. And there's actually lots of benefits with STN in addition to tremor control. Of the two targets, it actually allows us to aid patients in lowering their doses of medication. And so for a patient who takes high doses of medication or takes the medication frequently during the day, and perhaps there are side effects associated with that, that can be a huge help for the patient. So lowering medication and controlling tremor, these are great reasons to use the subthalamic nucleus. The GPI is a different structure, but overlapping in functionality. We typically use the GPI to help people with aspects of Parkinson's disease like rigidity, patients with severe fluctuations in dyskinesia. GPI can be extremely helpful for these symptoms. We see benefits for patients with tremor as well, but probably not as much with the subthalamic nucleus. In my practice, we do about 50% of patients getting the subthalamic nucleus and about 50% getting the GPI, because we really try to tailor each surgery to each patient as his or her own sort of individual plan. The VIM, the ventral intermediate nucleus of the thalamus, is the part of the brain that was, by the way, first approved for deep brain stimulation a long time ago, but for tremor. And it seems to be, at least in my practice, most typically used for patients with essential tremor. It's also helpful for certain patients with Parkinson's that have tremor at rest, perhaps in the absence of other Parkinsonism or other symptoms of Parkinson's disease. But typically this is the target for essential tremor. One key aspect of deep brain stimulation as a therapy, as a way to strategize how to implement it in our clinics, has been revolutionized by the ability to use image guidance. Surgeons like me have used image guidance to implant our electrodes for decades. And of course, that image guidance has improved over the past decades, even very recently. Now, neurologists that are programming the device can use image guidance as well. And I've always said that now, in some ways, thanks to this incredible technology from Boston Scientific, neurologists and neurosurgeons can sort of speak the same language about this therapy. With that in mind, Boston Scientific released the Vercise Cartesia X electrodes. These are electrodes that have become sort of standard in my practice. They have 16 contacts instead of 8. And what that means is there's lots more opportunity to deliver this therapy across a broader region and to deliver therapy in a more specific, controlled fashion. I can say that because of image guidance, which is a technology we've been using now for a while, that really allows us to adopt these new electrodes and more rapidly decide which of those contacts can be used to optimize the therapy. In addition to that, Boston Scientific has released Illumina 3D. This is an algorithm-based approach that uses the patient's imaging and leverages image-guided programming to more rapidly guide the programmer as to exactly where that sweet spot is. And between these two technologies itself, we can truly offer patients more personalized outcomes in a much more efficient way. Based off of our experience with image-guided programming, we've seen patients get better from a Parkinson's standpoint in terms of decreasing their UPDRS scores. We've seen how incorporating this type of technology can allow us to simplify and reduce the amount of time patients are spending in their clinic and kind of get to that sweet spot even faster. And these effects seem to be also quite durable. These electrodes are all the Cartesia X electrodes. On the left is a subthalamic nucleus implant, and you can see just a perfect example of why image-guided programming is helpful. We can use this image to sort of find the sweet spot much more quickly and save you and the patient hours of time. The bottom contact and maybe the bottom two contacts there are very close to that blue structure. That's the substantia nigra. I wouldn't even waste my time starting there because I know that those side effects can be delayed and I might not pick them up in real time. So I would start sort of in the middle range of that electrode, probably at levels 3 or 4, which gets me into the dorsolateral sort of upper zone of that subthalamic structure, which, we know to generally be the sort of sweet spot for people with Parkinson's. So just a nice depiction of why image guidance is so helpful. In the middle of the screen, you can see how the palatal target, the GPI, the globus palatus interna, or the internal segment of the GP, is a relatively larger structure than the subthalamic nucleus. And here you can see across the whole dorsal ventral axis of the GPI, you can actually see the Cartesia X overlays within it almost perfectly. It's almost designed for that structure. This can be really helpful for people with dyskinesia and Parkinson's dystonia and motor fluctuations, and you can see how there are multiple options that you can try. In my experience, I would probably start a little higher up there based off of the image guidance, which again in this case can be really helpful and really speed up your ability to find the sweet spot for that patient. On the far right, this is probably a patient with essential tremor, could be a patient with tremor predominant Parkinson's. And here you can see the electrode traverses the VIM, or the ventral intermediate nucleus of the thalamus, in pink. And you can see, again, the bottom contact is actually sitting below the thalamus there. That's probably, in my experience at least, the zone underneath the thalamus, called the zona incerta. And while that can be helpful for some patients, often when you stimulate that area, you can get cerebellar side effects, especially at a high milliamperage. So I would advise probably starting more dorsal along that array, kind of like I did earlier. And again, just a nice example of how you can use image guidance for all three of these structures, the STN, the GPI, and the VIM. Going one step further beyond just image guidance, this is Illumina 3D. So this is the algorithm-based technology released by Boston Scientific, now pretty common in my practice because it really speeds us up. And how does it do that? Well, you can see here the green structure of the subthalamic nucleus. And certainly I could use image guidance to try to optimize the field for that structure, but it turns out that there's actually a more sophisticated way to do that. And that really, in my mind, is Illumina 3D. So this is an algorithm-based approach, and you can see it's really easy to do. The software, you can visualize it here with the patient's MRI scan. To the right, obviously you can titrate the milliamperage or the dose of the stimulator, and you can also inform with very simple sort of notes here, what structures to avoid and what not to avoid. And again, this is the patient's own MRI scan. So this is the best way to personalize the therapy, and this can be done in the matter of seconds. This is a really nice visualization of sort of the different experience between these programming strategies. Illumina 3D really allows us to get to the sweet spot faster. This allows us to really hone our stimulation field and really design something that is personalized to this patient and optimized by his or her MRI scan in these critical structures that we want to either treat or avoid treating. On the right side of the screen, you're seeing this sort of traditional monopolar review. There's still a place for this approach in taking care of people with Parkinson's, but I would say it's probably in the minority of cases. But with the traditional monopolar review, relatively speaking, you're sort of doing it in a bit of a blinded fashion. And that doesn't mean you can't come to the sweet spot. And in fact, in my experience, if I do a monopolar review, I sort of end up in the sweet spot in the same location as the Illumina 3D gets me to, but it takes me, instead of seconds, it takes me often many minutes and potentially hours of time. Not only am I trying to share with you some of the latest and greatest, some of the cutting edge technologies of deep brain stimulation, which I find fascinating and inspiring, and certainly our patients do as well. But I'm also sharing with you technologies that are clearly helping our patients, and they're helping us. They're helping us help our patients. Surgeons have used image-guided approaches, for decades, but now neurologists are using them as well. And initial data is suggesting that the large majority of patients, 84% of patients, are reporting improved outcomes and improved quality of life using this image-guided approach. Not only are we able to get our patients feeling better, but we're able to do it faster. And this is really important. We have to be practical. None of us have as much time as we would like to have for each individual patient. And so it's really important to be able to use the time we do have wisely, efficiently, and image-guided programming really does get us there. Time always dictates whether these therapies are helpful, and we're seeing our patients benefit from this image-guided approach in a durable fashion, stable at least for 1 year. I've been inspired to take care of patients with Parkinson's disease and essential tremor. Ever since I was in college, I saw deep brain stimulation for the first time, and I never wanted to do anything else. But I have to say, I don't think that any of us, myself included, do deep brain stimulation enough. I think it's an incredibly underutilized therapy. Still, the minority of patients with Parkinson's and essential tremor are able to get access to people like me and have a neurologist take care of them with this therapy. There's lots of reasons for that. There's really just not enough of us out there to take care of these patients. The majority of people with Parkinson's never get in to see a movement disorder neurologist. And that's not because the movement disorder neurologists don't want to see them. There's just not the capacity. There's not enough space. There's not enough neurologists. And so in my practice and how I've reacted to this is that I've developed the expertise to do evaluations in these patients, the on-off testing that we talked about earlier, where I can actually see how the medication is helping them, and that can allow me to predict how deep brain stimulation would help them. For me, that is a wonderful way for a surgeon to sort of do his or her part to try to make this therapy more available to patients. The other is to work with neurologists who perhaps don't have as much expertise in movement disorders in a way to complement that. You know, I'm a movement disorder specialist. I might not be a neurologist, but I do have the experience with this therapy and understand how it can help patients with tremor and Parkinson's disease. And this way I can partner with general neurologists who might be comfortable with the medication strategy, and then I can bring the expertise on the programming. And the good news is that because now we have the ability to see where we're stimulating with image-guided programming strategies, thanks to Boston Scientific, people that have a little less experience with this therapy can feel more comfortable. I have colleagues, not just in Pennsylvania, but across the tri-state area and across the entire country, who refer me patients for this very strategy, because access really should never be the obstacle that gets in the way of patient care. I am very grateful that the movement disorder neurology program here at Penn works with me in an extremely collaborative way in order to bring this therapy to many patients. Of course, I get referrals from them, and I'm always grateful to take care of their patients. But I also know that they're for us if we have complicated patients who need a multidisciplinary approach.